There are forms on the table if you wish to extend a written question, and you may hold it up for staff to take to the podium. Last year, before a City Club audience, Dr. Carol Lindemann, who's the Dean of the School of Nursing at Oregon Health Sciences University, chronicled the crisis in healthcare for Americans today. Things like high medical costs, rising faster than the Consumer Price Index, poor health status measures compared to other countries who spend less than the United States, and 37 million uninsured Americans. Clearly, we haven't made a commitment to health care as a right for all Americans. Imagine then how we fail to address the health care needs of migrant workers who reside here for months at a time while they harvest our crops. Our speaker today, Dr. Tina Castanares, is keenly aware of the health problems of Hispanic migrant farm workers in the Columbia Gorge, both as the public health officer for Hood River and a practicing physician at La Clinica del Carino. Dr. Castanares has committed her considerable talents to care and advocacy for underrepresented populations. She'll bring the benefit of her experiences in these roles in her presentation today on the health problems facing migrant workers and their families and the resources available to them. Dr. Castanares is not limiting her efforts to Hood River alone, but is helping to shape health policy for Oregon as a member of the Health Services Commission. This is the group appointed by the governor that has worked to define a set of basic health services that should be available to all Oregonians, beginning with the Medicaid population and the expanded eligibles and employees of small firms. I could spend more time detailing her professional activities, academic appointments, travels, musical skills, and other interests, but we'd like to hear from her directly. The City Club of Portland and Hispanics in Unity for Oregon are pleased to introduce Dr. Tina Castanares.
Thank you, Mary, and thank you to all of you. It's a great honor, of course, to be invited to speak with you today, and it feels like a great opportunity to me as well to talk with you about a topic that is so important to me and so compelling, I think, for all of us. I'd like to start with what might seem like something of an odd note. I'd like to share with you a letter to the editor that was printed just last week in one of the local newspapers in the community where I live. In this letter, in referring to foreign nationals who are in the United States, and I think in our area clearly referring to migrant farm workers, this writer states, and I quote, "By working for less, they are not only leaving themselves open to exploitation, but they are also undermining the minimum wage earners of this country, of which there are millions. By working for less, they can apply for and get welfare, food stamps, WIC programs, subsidized health care, and subsidized housing. Aren't we, in fact, subsidizing anyone who pays them less? I can't fault anyone for wanting a better life, but why take away any incentive to do it for themselves? Why make their presence in this country such a burden on the taxpayers and social services? I feel we are creating a welfare way of life for these people, one they will never get out of because they have no reason to. Hopefully our government will get their heads out of where they've been and stop making crossing the border so attractive. Federal, state, and local agencies are tripping over one another, doing for migrants, while many of our own poor are homeless and without hope of a better life. We must get our priorities straight. I'm sure you would be surprised to know how many people feel this way." Well, when I read that letter, I felt immensely sad. There's so much in it, explicit and implicit, of the misconceptions and the misunderstandings and the lack of knowledge of how the American mainstream thinks and feels about migrant workers. And these misconceptions persist, even in spite of the facts. There are numerous studies, for example, that demonstrate that farm workers pay far more in U.S. taxes than they ever draw out in public benefits. That when foreign nationals are deported, there's a labor vacuum which is created, which there's just no U.S. citizen workforce anymore willing or able to fill. That it's a work ethic a very strong work ethic that's probably unparalleled by any other identifiable sector of our society that characterizes this group, rather than anything like a welfare mentality. That the United States has made crossing the border anything but attractive or easy. And that despite some gains in services to migrant and seasonal farm workers, it would be quite the stretch to say that agencies are tripping over one another doing for migrants. On the contrary, the social and the economic and educational and healthcare needs of this group far outstrip the modest efforts of U.S. society to address them. Are there people in this group who remember a television documentary made by Edward R. Murrow about 20 years ago called Harvest of Shame? Yeah. It was really pretty horrifying, wasn't it? And did any of you also see a follow-up documentary made about 2 years ago called New Harvest, Old Shame? That follow-up showed that what few systematic attempts have been made to improve the lives of migrant workers in the U.S. have been largely ineffective in the face of continued poverty and discrimination and outright exploitation. It was really a pretty horrifying documentary as well. And by the way, New Harvest, Old Shame contained footage that was shot recently right here in Oregon. But going back to that letter to the editor, I think what makes me the saddest and gives us all perhaps, I hope, the most food for thought is that phrase, while many of our own poor are homeless and have no hope of a better life. Now, if a society is, as my dictionary defines it, a body of individuals living as members of a community, or the ecological definition, a closely integrated group held together by mutual dependence and exhibiting division of labor, then I really can't imagine who qualifies more as one of our own than a person who plants and raises and harvests the food we all eat and depend upon to live. Indeed, if we drew society, that mutually interdependent organism, collection of individuals, as a big wheel, then who more fitting to be the hub of that wheel than the farm worker? Bankers depend on farm workers for food. Teachers depend on farm workers for food. Flight attendants depend on farm workers for food. Politicians, construction workers, doctors, judges, secretaries, loggers, auto workers, the unemployed. We all depend on farm workers for food. It's that simple. That makes farm workers in America who harvest and process American crops very much our own in my book, regardless of what countries they were born in. So if farm workers are homeless and without hope of a better life, in the words of that letter writer, then America is neglecting them, neglecting our own. And if farm workers can't hold their heads high, America can't hold its head high. And if farm workers are in poor health, America is in poor health. And that's exactly where we stand today. The critical health problems that migrant and seasonal farm workers have and their unmet health care needs, which could be readily addressed with the right combination of will and available resources, remind us that the American body politic is neglecting parts which are crucial to its health. Migrant and seasonal farm workers in the United States number some 5 million people, a population that's roughly equal to the state of Minnesota. But unlike the population of Minnesota, there is so much we just don't know about migrant farm workers. They're a hard group to study because of migration itself. That makes it tricky. And also because immigration is difficult to count and to quantify. Nevertheless, what we do know, and that body of knowledge is growing, is already quite impressive. Agriculture, for example, ties with mining as the most dangerous occupations in this country. And yet, strangely, exceptions and waivers from the occupational health and safety laws are commonly made for farm workers and for agriculture. In 1988, 48 out of every 100,000 farm workers died of work-related accidents. That's 5.5 times the national industrial average. Farm workers have the highest rate of toxic chemical injuries of any group of workers in the United States, more than the workers who produce those chemicals or process them at their plants. Yet there are no good studies on the health effects of long-term pesticide exposure, and few federal standards, really, for chemical safety in agriculture. And more than any other working group, farm workers collapse and often die of heat stress and dehydration in the fields. Environmental conditions overall are very, very poor. There's non-existent or at best dilapidated housing in many areas. Insect and rodent infestation. Substandard or non-existent potable water supplies or washing water supplies. Inadequate disposal for wastewater and solid waste. Unsafe use of pesticides and equipment. Lack of hand washing and toilet facilities in the fields. Nationally, over 35% of farm worker housing lacks inside running water. Only 22 to 40% of all employers provide even minimal toilet facilities in the field. Even where laws and protection exist, they go unenforced. As an example, only 4% of North Carolina's farm workers, 4%, have access to the basic sanitation that is provided by law in that state. These are just some of the environmental factors. Has anyone here seen any farms or labor camps like those I'm describing? Some have. I had been working in migrant health for more than a year. This was in California before I began to do house calls to labor camps, and it was a very rude awakening. A lot of the medical advice that we commonly give was totally inapplicable given the conditions in the camps. Here in Oregon, I spent the better part of 2.5 to 3 years doing nothing but house calls as my clinical practice to farm workers in labor camps and in homes. And please believe me that the conditions that are described for the national picture are applicable right here in the Northwest and right here in Oregon. And of course, I have to emphasize that there's no health clinic or sympathetic doctor or nurse that can make these conditions go away, as crucial as they are to health. Well, what about here? A 1991 state study estimated that close to 160,000 farm workers and their dependents are living and working in Oregon at peak season. That would come to about 5.5% of the total population by census count, I think. Now, although the Department of Agriculture concluded that farming was Oregon's leading industry in 1989, involving $13 billion, or about 40% of the state's total economic activity, nonetheless, housing for the workers who are critical to this industry is dismal. It's unequivocally inadequate. Certified labor camps at that time had the capacity to house some 11,600 people. And yet at that time, 20,500 at a minimum were living in those counted units. A January 1991 study by CASA of Oregon looked at approximately 1,500 housing units for farm workers, housing at that time about 9,000 people. And over 28% had no garbage cans or garbage services, 19% had no locks, 36% had no smoke detectors, 15% had no heat. These are statistics for Oregon. So crowding, substandard housing and sanitation, chemical exposures. What other health problems do farm workers experience? Hunger and malnutrition, for starters. Nearly a third of migrants surveyed nationally in a 1989 study reported running out of food or not having enough to eat during that year. In fact, the incidence of malnutrition among migrants is higher than that of any other subpopulation in this country, according to a white paper published by Georgetown University in 1987. Then there are infections and contagious diseases. Migrant workers suffer 20 times the rate of diarrhea than even the urban poor do. Up to 78% of farm workers are infected with parasites, usually related to water. Again, that's about 20 times the rate for the general population. The death rates for farm workers from the flu are 20% and from pneumonia 200% higher than in the general population, the national averages. And we are seeing a very troubling prevalence of tuberculosis now in farm workers and in their family members. Some of the pressing health needs relate more to ethnicity than they do necessarily to being a migrant or to being a farm worker. Almost 100% of Oregon farm workers are Latinos, the vast majority being of Mexican origin, like myself. 4% of Oregonians who were counted in the 1990 census declared themselves to be Hispanic. I want to point out, though, that there are a lot of us who feel that was a gross underestimate of the Hispanic farm workers living in the state. Well, so what are some of the special health problems that Latinos face? Hispanic women have 7 times the risk of serious cancer of the cervix than women in general. Mexicans have higher rates of high blood pressure than non-Hispanic whites, as well as higher cholesterol levels. Diabetes is such a serious problem for Hispanics that addressing it is one of the national priorities for health in the year 2000. Our risk of getting diabetes is 300 times the risk for non-Hispanic whites, and it has a much greater chance of leading to blindness and to heart failure. Mental health and substance abuse problems within farm worker communities haven't yet been adequately studied, but are clearly significant and dismally neglected by a healthcare system not designed to suit these needs. And dental disease is widespread and largely untreated. In my own clinic, we did assessments of migrant adults and children, large numbers, and found that well over 80% had dental problems needing treatment. So what stands in the way of preventing or treating these health problems and conditions? Besides the social and political solutions that so clearly need to happen to address poverty and environmental hazards, the healthcare system too will need to change drastically. Although federally supported migrant health clinics like the one where I work in Hood River can help by making medical care available at a discount, we've been shown, unfortunately, to serve fewer than 20% of migrant and seasonal farm workers in this country. There just aren't nearly enough migrant health clinics to go around, not enough reach. Besides, we can only discount what we offer within our own 4 walls. In other words, we can't help with problems like that need hospitalization or referrals or special testing or medications, durable medical equipment, and so on. People need insurance to get help with things like those. And farm workers are the least likely of any labor force in the country to have health insurance. Without health insurance or subsidized medical care, as you can imagine, timely access to services is not going to happen. In 1975, if I picked a ton of apples, I would get enough, about $14, to pay for a routine office visit to the doctor. 10 years later, in 1985, that rate at best would have gone up to about $16 for picking a ton of apples. But meantime, doctor's visits doubled, or more than doubled, in cost. Today, an apple harvester in the Northwest would have to pick some 5 to 7 tons of apples to pay for a routine chest x-rays. As one study has noted, in an entire apple harvest season, assuming the family did not eat or pay for housing or buy anything whatsoever for a whole year, it would still be impossible for a migrant family to pick enough apples to pay for any really serious illness or major surgery for any member of the family. And of course, outright medical costs aren't the only financial issue. A day or even an afternoon's lost wages away from work for any working member of the family can be an economic setback, even an economic disaster. So most adults are very reluctant to take time off to seek health care, at least until problems or pain become quite advanced. Now here in Oregon, we're a pretty savvy population usually about Medicaid. We've all heard a lot about it, at least with respect to the Oregon Health Plan. But even so, I find that just as much here as in other states, most people have the wrong impression that farm workers get their health care paid by Medicaid. I wish that were more often the case. In fact, the vast majority of Oregon farm workers are ineligible for Medicaid for regular health care. So, be it private or public insurance, farm workers go without. So, this is the difficult picture of migrant and seasonal farm workers' health. Please stop and think a moment about your own age, and then reflect on the fact that the life expectancy for a migrant farm worker is 49 years old, instead of the national average of 75. And think for a moment about all the articles that you read in the paper about our dismal infant mortality rates in this country compared to other industrialized countries, and how alarming that is. And then consider that the infant mortality rate for migrants in the United States is 125% that of the national rates. What needs to happen? Well, and as I try to give some ideas, clearly they're my own personal points, I would point out that perhaps City Club and City Club members in your own committees and subcommittees can begin to look at addressing some of these, because it will need a concerted effort by all of us in this society to do better. But what needs to happen? Well, health care insurance needs to happen. Employers and government are going to have to collaborate to make sure that farm workers get health insurance. Period. Without it, there isn't access to the medical care that they need and deserve. Housing needs to happen. Employers need to stop saying it isn't a problem. I can't tell you how often I hear that. Neighborhoods and local governments are going to have to stop passing the buck and saying that farm worker housing is okay, but please not right here. Somewhere else is okay. Financial institutions, small businesses, nonprofit agencies, state and federal agencies need to collaborate on such things as home purchase programs for farm workers who want to settle. They represent an increasing proportion of farm workers. The initial investments in these sorts of programs pay off manyfold in stable and safe populations, even in property tax revenues, and in fewer health care and social service costs. New services, expanded services, and creative approaches need to happen. Migrants have special needs, as do recently arrived immigrants. In the clinic where I work, my fellow workers do really innovative outreach work in labor camps. And we have lay health promoters who serve their own communities with a special sensitivity, and at the same time are developing real community and grassroots leadership by their work. But efforts like these, which are usually funded short-term as demonstration projects and so forth, need a commitment of funds to keep going and to serve a broader range of people. At the same time, more health department clinics, migrant and community health centers, mental health and substance abuse treatment centers where Spanish is spoken, and subsidized dental clinics must be established and funded where people will use them. Social and community activism needs to happen. Needs to make all parties accountable for providing proper sanitation and housing, for respecting workers' rights, for respecting their dignity, for complying with fair laws and protections, for passing those laws, and for revoking the exceptions for safe housing and occupational and child labor standards that are allowed still in agriculture. Most of all, I think, a true sense of welcome needs to happen It needs to be extended on every front. Migrant and seasonal farm workers are our own. They're part of our extended family. They're essential parts of our mutually interdependent society. It's long past time that we begin to treat farm workers like we would like to be treated. To do less is obviously imprudent and short-sighted. We'll continue to pay in 1,000 ways for our neglect until we turn it around. More importantly, to do less is inhumane. Personally, I've never known any group of people who work as hard, who value their friends and their families as beautifully, who hold such strong family values, and who have greater strengths of character and culture to give to our American society. Ironically, I would echo one sentence from that letter to the editor-writer. We must get our priorities straight. I would ask you all to champion the cause of farm workers, because their cause is our own cause, and because they deserve our utmost appreciation and support. Thank you.
Dr. Castanares, you said you were worried about telling us too much bad news when we were up here having our lunch. We're worried in this urban club what we can do about it. I want to know how can the farm workers get clout? Who will speak for them? Who will listen? Is there a Cesar Chavez out there somewhere in Oregon?
That's a big question, Andrew. Well, I think first and foremost, farm workers can speak eloquently for themselves. I said a few things there at the end about I've never known a group with as wonderful family values and with as strong a work ethic and so on, and I could have added I've never known a group of people who can speak extemporaneously and so eloquently as the folks I've met who are farm workers and who speak in forums. But we do need to help to provide opportunities for that. Ones which are truly respectful and bring farm workers to the table as equal partners. I think that's very important. So something that those of us who are not farm workers can help to do to allow farm workers to speak for themselves is to make more of those opportunities happen. And in speaking for themselves, certainly personally, I think there is a role for organizing, occupational organizing. The big U word, unions, is anathema in my community. No such efforts have existed where I live. I wouldn't say there is any single well-known character that is known to the state like Cesar Chavez was and is known to the nation, but there is already a farm workers union that is active and in growing stronger in the Willamette Valley, PICUN, Piñeros y Campesinos Unidos del Noroeste, which is Tree Planters and Farm Workers United in the Northwest. It's a larger topic, what union organizing does to give people in any occupation a voice. But to generalize, I'd return to the most important piece, which is allow farm workers to speak for themselves and help create opportunities for them to do so. They're well aware of their needs, and they have the best ideas on how to address them.
Sandy Marin, City Club member. Under the Oregon Health Plan, which many people are optimistic that President Clinton will sign the waiver for, will the migrant workers be adequately covered under that plan?
That's a great question, and I think I can answer it, but forgive me because I think not anyone can answer it with certainty yet. Those who would be eligible without immigration or citizenship problems attached to their eligibility would become eligible under the expanded eligibility proposed in the Oregon plan. They should be able to get Medicaid. I look forward, for example, to many of my patients, including many of my farm worker patients, becoming newly eligible and then having Medicaid insurance. However, there are complicated immigration-related exclusions from Medicaid. These aren't Medicaid's fault. They relate to immigration law, which to date has superseded Medicaid regulation and statute. Some of that is in flux, so I could speak to anyone who wants more details about that at the conclusion of this. But suffice to say that the real sticky point when it comes to farm workers and Medicaid eligibility has to do with citizenship and legal residence status. In some circles, I'm thought to be, I suppose, more radical about this than others. I favor what's done in many other countries, which is coverage without respect to legal residency, because I think it's a humane act, and I also think that it's a prudent one fiscally, because people who are living in our country and have health problems end up coming and needing health care at a higher cost, and we all end up paying for that. But that's not the direction that policy is taking yet.
Ralph Crawshaw, City Club member. Tina, would you say a little bit more about the problems of the interface between the minority group and the general population? Namely, I'm speaking from the Oregon Health Decisions viewpoint of trying to have grassroots health policy that is genuine grassroots health policy, and going to minority groups and finding that we have great difficulty in getting people to speak. Namely, they have trouble coming to meetings, they have trouble with language, and we have a reputation nationally, Oregon Health Decisions, of being just another WASP organization. And despite our valiant attempts to reach the different minority groups in Oregon, we need a lot of help in knowing how to do the job better. Thank you.
Thanks for your question, Ralph. And I think the best way I can answer it is to tell you a saga of how much I've been humbled along this line over the years. Used to be that I felt it was really important to translate all of our pamphlets for patients into Spanish and hand them out madly. It took a while before I realized that they were not being used well by people who read the originals in English, much less folks with varying degrees of literacy and kind of orientation to written materials in poor translation in Spanish of stuff that was probably poorly written in the first place. So I learned that there need to be different approaches for educational materials as a doctor. Then I thought, I can go door to door as a doctor, and that's what I really want to do, and take medical care to where people live and work, and I'll do health promotion and I'll do education there where people live. And I got humbled very fast to see that the really effective people were the lay health promoters that I was supposed to be teaching and mentoring. They were the ones who did the good work, and there were much too many barriers for me to do good health promotion education, even in people's homes. So over time, I've learned that some of the best efforts that we think we're designing we're actually sometimes inflicting on the community. And where we must start is getting the ideas themselves from the members of the community. Now that itself is an art, and I think you're alluding to that, Ralph, to say that it's hard to find forums and to create opportunities where that voice will emerge. But it's getting less hard all the time, and there are innovative programs out, including lay health promoters, as I've mentioned, community meeting groups that they facilitate. Gloria Muskis is here today in our audience and also works with promoters involving Hispanic seniors. So throughout our state, we have some examples of ways in which the community is speaking for itself with a voice that we ought to listen to. The danger, again, is for us to inflict a format, a set of expectations, reporting requirements, and all those kinds of things, because they don't fit the community.
I'm Ray Polani, City Club member. Dr. Castanares, isn't it part of the problem, perhaps, that the family farm in the U.S. is all but disappeared, and that farming is now being conducted by rather large corporations, agribusiness, and so on, and so, and if not by that, probably by cooperatives. It seems like as the farmer gets squeezed out and the big corporation takes over, that probably the only choice for the labor is to organize and present some sort of a united front that can bargain and obtain what they should be receiving. What do you think?
I think you raise great points. I really lament the collapse of the family farm, although in my community there's still lots of family farms, thank goodness, but I think it's a really sad loss for a lot of reasons. When it comes to what it means for farm workers, it's a mixed issue. There are some farm workers who have historically been treated best by small farms and small businesses and small farmers, but at the same time, some of the most horrific accounts of abuse or exploitation have been in small businesses, and it's been where there's a transformation to large agribusiness where farm worker organization can take place and there's enough mutual support to make change or to resist exploitation. So that's a mixed bag. As to your point about organization, again, I'd say what I did before. I personally think that organizing within occupations and with representatives that can go to the bargaining table has generally been a good thing for labor in this country when it's not been corrupted. We're not near a place yet where that's going to be widespread among farm workers, though there certainly are efforts to make that happen and to represent farm workers. And I watch that with a lot of interest because it may indeed be what's necessary. You know, in my profession, you hear doctors talk a lot about we'd better start monitoring ourselves before they start doing it to us. And I think that I'd like to hear more farmers talk that way about their workers because some of the things they hope to hold at bay, like unionizing, will inevitably happen if they don't make the changes that are necessary to treat people more humanely.
Dan Goldie, City Club. Under the basic statute under which the United States Employment Service was created, there's a provision that requires that before labor is cleared from one area to another, brought in, that the jobs must offer the prevailing wages and working conditions. I used those provisions back in the 50s when I was regional director of the manpower programs in the Northwest to raise and create the prevailing wages for farm workers and to raise the conditions, housing, other conditions. My question is this. I'm sure there's been tremendous deterioration in the standards since those days of the Great Battle. But I wonder if the people that you work with are addressing the fact that there is a statute on the books, if observed, if the administration would do what authorities permit them to do, whether then you could in effect deal with some of the problems you've been addressing, and whether within the concept of prevailing working conditions, medical care could be part of that issue.
Thank you. If I understood your question right, so please return to the mic and correct me if I did not. You're asking if I thought that there could be enough teeth in the standards that exist to go enforced, perhaps again, and if medical care could be brought into the standards, that some modicum of medical care would have to be provided or some benefit package.
Yes.
It's something I've never thought of before. Go ahead.
The point being that medical care, some degree of Medicaid medical care, is a part of the prevailing working conditions for workers. The statute talks about not bringing workers from one area to another unless what is offered to them are prevailing wages, working conditions. What I'm asking is whether or not health provisions couldn't be considered a part of it. And my second question is whether or not anyone is looking at the question of whether any of those standards are being currently applied?
Let me take the second part first. I think people are. We certainly have folks in this state, too, very actively trying to do inspection, do enforcement, create penalties when there have been transgressions from standards and so on. But I think most would agree that those efforts are drastically understaffed. And that's one of the things that allows so many substandard conditions to go on. So yes, people are looking at that, but I don't think there are yet resources sufficient being brought to bear to carry them out as they need to be carried out. As to your very intriguing suggestion that medical care be somehow enveloped into the standards and then that those standards be enforced, that would allow people to basically to hire workers, I'd love to see something like that. I've never dreamed that high, perhaps, at least not in the realm of labor and business taking care of itself in that way. I have tended to think that the solution is going to have to be some kind of uniformly applied health insurance with access to all, and that's still where my heart lies. But I think it could be quite useful to do something as you suggest, as long as there is a good consensus on what standards are. I know that there are employers who take such a personal interest in their employees, they'll bring them to the doctors, they will pay for their medications, they will keep them off work, they'll visit them, they'll take them hot soup. I mean, there are wonderful employers. And there are others who don't even want them to file very clear-cut workers' compensation claims or go to the doctor. So there's the whole spectrum. Given that heterogeneity, you'd have to have standards that are agreed upon and written down to make what you're suggesting work.
I can add another question that came up from the audience from John Bartley, which takes a little different tact, and that is to convince the voters that basic health measures are desirable, first they must be convinced of the economies. I think talking about the payoff. What would basic health care and occupational health measures cost the food consumer percentage-wise in the cost of food consumed? And are there any authoritative studies on this issue?
Wow. My answer to the first question is I don't know. I'd like to know. And if there are studies, I haven't seen them, but I'd love to see them. I mean, I think that's an interesting question. If we could add to the price of the food we purchase, somehow what would be required to fund medical care for the folks who pick it and who plant it. I think that's another intriguing idea, but I'm not sure that that's been costed out. It'd be kind of complex.
Hi, Bruce Hall, City Club member. I was going to ask the Zoe Baird question, but Dan Goldie beat me to it. So I will skip enforcement. Let's ask you something on the statistics. You said that in North Carolina, 2% was the compliance with the overall law.
4%, I think, 4%, yeah.
4%, okay.
Pretty low, yeah.
And my question really relates, there's been a lot of feeling on my part here today that apparently there isn't good statistical information on a lot of these questions yet. And for instance, in Oregon, if I ask you the question, what's the percent of compliance with our laws, you might not know. Maybe you do know. But my question is do you know who or what organizations are studying these problems? Is it Portland State? Is there anybody you know about that is developing good statistics to work with on compliance, standards, the state laws as distinguished from the federal laws, and so forth?
I think that there are several state agencies and some federal that would be good to tap for information on these various questions. EPA and OSHA come to mind. The State Agricultural Commission, which as you may know is kind of in flux under the governor's office, comes to mind. The immigration offices, of course, will have information that's useful on questions related to their focus. Portland State has a great Center for Population Studies. I'm not sure if they're studying the other things you mentioned. One of the problems with, say, housing and environmental issues in sanitation and so on, when it comes to farm workers and their labor camps, is that there is such a diversity of organizations with different authorizations and bailiwicks and so on. So it's hard to get information from one source. And another is the understaffing of folks out there. For example, the Oregon State Health Division has a center, a department on pesticide intoxication, but it's very minimally staffed. And so there isn't an opportunity to go out and visit sites where there's been a reported or suspected exposure and so on. It's very hard to get the follow-up information. The Bureau of Labor, Bureau of Labor could be asked for some things.
Perhaps before we leave this topic, I'd like to ask one question in your role as a Health Service Commissioner. Could you help us understand a little bit about the basis for the objection to the Oregon Health Plan with respect to disabilities, how the Oregon Health Plan ranking was considered to discriminate against the disabled, and what changes have been made to give the state hope that that will be approved?
Okay, that's a shifting of gears. So let me try that. Let me rephrase the question, and if there are folks here not familiar with it, the Oregon Health Plan was submitted to President Bush's administration and then was nixed there and was denied the necessary permissions to go forward. And the reason given by the administration was that it had the potential to, if it were implemented, to violate the Americans with Disabilities Act, also called the ADA. And in dialogue with federal attorneys and the Department of Health and Human Services that followed, what we learned about their reasoning was that in their minds too much had been made in our methodology of prioritizing health care of this question of quality of life. That is to say, we asked the public a lot, and the public responded to us that quality of life was more important to us, or at least more frequently emphasized than length of life. And we also surveyed the public with a telephone survey in which quality of life issues were the focus. Would it be more acceptable to you, for example, to have very impaired eyesight than to be unable to walk? And these were thought to be, correctly, I think, quality of life questions. And the reasoning of the administration was that quality of life questions and issues should be a taboo topic because they have the potential to introduce bias and diminish the value of life of a person with a disability. In other words, to say that a person unable to walk might somehow come out less valued than a person who is able to walk. So that was their reasoning. And our response then, after quite a lot of talk and consideration, as you might expect, was to redo, with a new methodology, the prioritized list. We discarded all the data that was obtained from the public by the telephone survey, so it didn't enter into the new methodology. And in our own discussions and deliberations, we tried scrupulously to eliminate quality of life considerations in our own thinking. Things that were allowed to be considered had to do with cost of medical services, effectiveness in the minds of doctors and other practitioners, public health considerations, in other words, is something very likely to spread to a lot more people, and some others. And in resubmitting a list that was built up on those parameters, we have since asked the Bush administration to reconsider, which I think they're declining to do now, and the Clinton administration will be looking at the proposal again.
You can see how well Oregon is served in Hood River and on a policy level by Dr. Castanares, and we appreciate your sobering report today and making us more aware of the needs to serve our fellow residents. So join me in thanking Dr. Castanares, and we will be adjourned.